First of all, thank you, Beckman, and thank you, Rajesh. Before my slide gets, he has covered most of the session. Since we have 2 minutes, I'll share something very funny with you all. Actually, we were supposed to get a clinician in this event. We tried the best of the clinicians who understand what is PHI. I'm sorry to say that, because pathologists also are not even in the grey zone, in the black zone is what I understood. Finally I said, Arijit, don't worry, we are there. But when we said we are there, I was sharing with their team yesterday. I did speak to Dr. Seema Bhargav, who is, from Gangaram Hospital and using this extensively. And she said, Aparna, you are not using PHI? I said, okay. I said, I am no longer into that organization which you think where I was, because when you are outside, you get 1 PSA per week and getting a PHI. I said, but what's your experience? And I think what she told me about Indian data is very, very important. I'm trying to share that with you. But apart from that, I took the liberty of putting Rajesh as a main speaker in this without asking him. Yesterday morning he came here, you will not believe, and so I think he deserves a big round of applause. And I don't deserve anything because I didn't even ask him. I just put, that's what friendship is all about. I said, koi nahi hai to Rajesh rahega, because if you've seen the agenda, I'm also up. So I said, ye baat kar lega. And look at we were dancing till 12:30, those who have seen us on the dance floor. And this is done in the night, what he has presented today. Immense. And I think your team also helped us in understanding it. Yes. So, I want to share 2 things. This is the Indian data, what you guys were asking. I think the take home message, what you have understood is avoiding unnecessary biopsies. Okay. There is a lot of overlap between positives and negatives which you saw. But I'll share with you, those who are from Mumbai have heard name about Dr. S.D. Bapat, if you have heard. One of the stalwart as a urologist. And I used to be always having that, we call as KIDA, to do something new. So I think 3 years back, we started talking to him about a clinical trial where he said, let's do a DRE, a PSA, free PSA, and let's do a study. I said, sir, that's already retarded study. If you want to do something, let's do a urine PSA. Because I was in one of the event in Japan, and that's when I saw urinary PSA levels. So we did try to standardize that kit, and we did a lot of study. For my ignorance, I think I was not aware of this 3 years back. And we did a study which was based on PSA velocity. I want to give you 2 things before this data. Is anytime what I learned from this team of urologists is when they do a marker, any marker for the matter of fact, what they look at is the velocity, the change in the value of the baseline PSA, the first day PSA or PHI, the same thing applies here, from there onwards to the next value. And ideally it is said that it has to be the same laboratory, because I think when you change and hop, every time we all know CVs change, and they are very, very fluctuating. So, first of all, thank you, Rajesh, again. Yeah.
Announcement I got.
Please.
All those who have not checked out of their room, please check out, because after 12, you will be charged for the next day.
Yeah.
So, anyone who has not checked out of the room,
but we can take 15-20 minutes. Put a message. Who has sent? Vipul? उसको डालो, 1 बजे करेंगे, अमित से बात करो. Sorry. नहीं तो people will run from here and I will be here. Even I will have to run. Okay. So, this is a cap data. I mean, basically a trial where, unfortunately, what is happening today, as Rajesh covered, I saw a couple of slides, is when the range of PSA, which is still considered, is between 4 to 10. That is where the grey zone is, right? That's what, and we are worried about it. But I have also seen that suppose you have a patient, for example, what I was mentioning about velocity. You have a patient whose PSA value is 2.5. Okay. Next year, there is a PSA in body profile. He is not bothered. He comes and does a PSA and the value is 3. The normal range is up to 4. Do you think this is significant? It is significant. That's what I mean by velocity. Even such patients come into this kind of category. So, if you see, the CAP data shows that the age group which was covered was almost 1,89,000 men. मेरे को pointer मिलेगा तो अच्छा होगा. नहीं है तो छोड़ दो. So what happens if you do not do a screening? If you can see, it's a very self-explanatory kind of a thing. If there is no screening, that's a good news. 68% will diagnose. So basically, I was checking out with Seema, Dr. Bhargav. Do you have this as a screening protocol in Gangaram? Because that's a big referral hospital. We do send, I have remembered, we do send hemoglobin electrophoresis confirmatory test to Gangaram. So it's one of the referral centers. She said, yes, they have included this in all executive packages. They are no longer asking PSA or free PSA. It's direct, So if you are not going to screen, if this is a screening program, so many people will be diagnosed, so many will die, so many will be treated. Clear? But if you do with screening, 88 will be diagnosed with you. It's evident from the figure, and thanks to Arijit, he has shared this with me. It's not my data. It's an Indian data, but thanks to him. 7 will die with prostate. So same number of death, but more number of patients will be treated. So in short, we are not going to diagnose false positives is what I feel, So, do you want to have a patient? I will share with you my very close family relative. He comes with a complaint of inability, retention of urine, very classical. So, the first thing which was told to him was to do a free PSA. Clear? Free PSA is a very dangerous parameter. How many of you operate on it? The quality control in free PSA is a lecture in its own. Okay, so you do it without controls most of the times. I don't want to generalize, but I have seen it. And when you give a ratio, you get a call. Maza benign hai ki malignant hai? Is my value benign or malignant? Is this the way you will grade it? Number 2, Ritvik, I want you to talk to Amit. Tell him at 1 o'clock we'll check out. Because none of my people can get out. उसका मैसेज आया है कि नहीं तो चार्ज लगाएगा. अमित को बोल. प्रतीक. Please request him. He will check out again. Thank you so much. It's a big amount. Okay. So we were at that. So we did the antibiotic course to the patient. 8 days. That's the way the protocol is. After that, total PSA was repeated. Total PSA was initially 8.3. It was repeated in our own lab. It came to 4.8. 4.7 or 4.8. He was told it's okay. It's now near the border. Okay. Do you think such cases should be just kept as, please. Kept as okay and left? In fact, the first thing what we should have done was PHI. Correct? We haven't done it yet. What we did after that was a prostatic biopsy. Okay. When you are doing biopsy in the best of the people, okay, first of all, there are few stalwarts in the city of Mumbai who are like blind hit. I can take the names of those urologists, like Dr. Joshi in Plaza, near Dadar Plaza. Mohan Joshi. He comes and there is a line every day. He does 20 prostatic biopsies. So there is the hit rate to that particular tumor is much better because he has a better imaging. He does a per rectal imaging and does the biopsy. But when we did this, we just got prostatitis. Okay. We haven't got anything else. We are happy about it. But again, we repeated after 15 days, the PSA levels. The PSA levels are 5.01. What does that show? That shows not choosing the right test. Only that. That is the only solution. Nobody's fault. Okay, the biopsy must have, you may say, but to err is human. If that tumor is very small, we are not able to visualize it. If it's a necrotic focus, and you have hit that. All that histopathology session will cover. But I think what I want to drive here, or what he wants to say, or what this parameter talks about is choosing the right test. That's why we all are here. Now, why do we need this? I think enough is spoken, but this is what the data is. If you see mortality to incidence ratio, this is our Indian data, thanks that we have 0.65%. The next slide. Now, basically, when this thing of mammography came up, I'll just shift my focus. Suddenly, when these pink days started coming, the breast, I respect those days, but what started happening is, every commercial radiology center started getting a mammo machine. Is machine what is going to report the breast? Unfortunately, no. I'll give you an experience. I think case studies help us understand better. Again, a very close person coming to me, 33-year-old, reported in one of the, mistakes do happen, but they are not because of intentions. The report is malignancy, advised to go for core biopsy. So, immediately there is a panic, they call, and since you are in the family. So, expertise behind the machine is what is all about. So, we took her to one of the reputed person who I know. She did mammography with USG guided, breast, which will, I think the radiology conferences if you attend, which gives the specificity of as high as 93% in breast. So we did, and she said, Aparna, nothing to worry. It's basically, long-standing mastitis. This will get recovered. You will have to put her on, the treatment on hot fomentations and painkillers, and after 6 weeks you repeat, there is nothing going to be wrong. So sure she was. The breast was as hard as what we have seen. Once you palpate it as a clinician, you do feel it's a malignancy. So there is a less amount of good professionals available, is what I want to tell you here. When you have urologists and even doctor to patient ratio you see in WHO, today in India, I think one doctor to how many patients? Almost, Rajesh, we just recently there was a data of about 1 lakh patients to one qualified doctor. We are standing there today. So can we afford to lose that content, that expertise on things which are not warranted for? I don't think that is required. So if you want a good urologist, he is human, he cannot see 100 patients. He needs to see only those which are on the red alert. Okay. So this test not only helps you to look at, yes, you are high risk, or we can neglect you and monitor you later, keep you under the radar, but also utilize your talent so that urologist OPD is only seeing those patients rather than having patients for unnecessary biopsies, increasing the burden on histopathology. Forget histopathology, the cost, the hospitalization, even if it's 1 day, okay, the loss of labor. Today we are employed, but if you have a daily wage, or if I am a consultant, I am not there in my lab, what is happening? I am paying somebody to go there and work for me, right? So it's a loss of labor also. So using your clinicians to the number of prospective patients, better hit rate rather than having the complete sea of people. So screen your people. It's a good way of presenting, I must say that. So, we all know the complications. Let's go ahead. So, how many unnecessary biopsies are happening in India was asked. Okay. So, these are the number of unnecessary biopsies happening. I want to tell you here that maybe this rate will be even higher, Adijit. The reason is, none of us are aware, us means I am talking about pathologists and clinicians, 4.5 आया तो लोग बोल देते हैं ठीक है. I have also seen that in maybe 2 cities, in slightly you move away from the major cities, say 50 kilometers away from Mumbai. I am just talking about that. We have seen कि 4.5 है, दूसरे लैब में रिपीट करेंगे 3.92 आता है. They keep the patient. It's like triple marker, what we discussed yesterday. It's not about shopping. It's about the CV. We all forget that. Maybe the biopsies may happen more if the clinician is reading. So not choosing the right test. Again, coming back to it, These are the number of unnecessary. I think the data must be even higher, possibly. We may go unnoticed.
This refers to the individual of cancer, but we can always explore further, like actually what is the.
That's what I think. But not having a data, it's better to have something. So if you see the gray zone 4 to 10, 30% percentage of total patients going for biopsy, accuracy 7.4. Okay, these are the number of patients where they are predicting that in 2019, the next year, so many cases will undergo biopsy. Next.
What we have right
I would like to share after this just one thing, that when I spoke to these two people, because I interacted with Dr. Sankhe, who is in Bhaktivedanta Hospital, very focused on to his work of urology, does a lot of work on PSA. He collects, I asked him whether semen sample, can this be done? Is it more specific than blood? Because anyway, blood is a non-invasive test, but semen is also. Whether the specificity increases, he must have told you the specificity, is something which we need to evaluate, because these questions do come to us because we have worked in that field. If that happens, it would help in getting more, or ruling out more false positives, possibly, is what you guys we can get you the clinicians to give you the patients, and we can look at improvising and maybe a ratio, blood versus semen, if that can help. Because this question was asked about urine PSA to me, whether we can do semen PSA, urine PSA and blood PSA and look at the ratio and the hit rate with histopathology. So similarly, this can be done. Choosing 5-6 good people who can give us patients and a good pathology lab which can work with you, I think it will help, and there should be no issue in transporting the sample, because motility is not a concern. Here only seminal plasma is what is required. That is my request to you all. That will really help us. I'm sure it will, because neurological markers, when we have worked in autoimmunity, there are data that should not, that there are no references, but lot of clinicians do ask blood and CSF, Even I have seen CA125 or people asking NK cells from endometrium and serum, where endometrium is more specific for infertility. So, with that, I think we are happy that you shared this with me, but I'll take back that message and request you all to help us whether we can do that for our clinicians, and it will help patients overall in our country. Thank you.
Can you say a little bit more about urine PSA? How does it fare in comparison to serum PSA?
See, urine PSA, I got a trial kit. Whether I can take I got the kit from one of the companies, imported particularly. We did roughly 808 samples of total PSA versus urine PSA. But it correlates very well. So, the problem about urine PSA was standardization and 24-hour sample. That's very cumbersome for the patient. So, I don't think that test will pick up, because it has no added advantage. But I learned, yes.
This urine PSA, has it been validated or not?
That's why it has not come.
Speculation?
Yes.
This is speculation.
Speculation.
Whether these kits will be different for blood PSA and urine
Yes,
PSA?
yes,
It will
yes.
be different.
The kit was different.
If it is there, it should be from the same manufacturer. Rather than using different manufacturer, you should have to be from the same manufacturer. The blood PSA is now very well standard.
Absolutely.
They should come out with the kit for.
The kit was under research. So this gentleman, Dr. S.D. Bakar, he holds an authority. So he wrote to the company and he was quite charged up about this. And since we were among the largest, doing around 200 PSAs per day, we got that chance of doing this study in a week's time actually. But unfortunately what we did was under the R graph, or when we did the comparative studies of total PSA versus urine, and we requested a repeat after 15 days for those which fall in 4 to 8 following antibiotics, the change was same, the drift was same. So what's the added advantage? Because troubling the patient for 24 hours scan, and if I'm getting more specificity, it would have helped. So now I feel like going back to, and since it's a learning process, we should be, actually all of us should be shifting to this.
One suggestion that we have to develop a protocol. So patient result falling in the range of 4 to 10, there should be a sequential estimation of this test result rather than depending on the one test result. If it is showing increasing values,
Just go back to that, I'll answer your question. Just go back to that equation of how do you derive that?
3 to 6.
Yes.
There should be a defined interval as to what interval we should carry out.
I have a question. How much do you charge
Maybe
for?
3 or 4 tests the blood test can be easily repeated rather than going for the biopsy procedure.
I agree, but let's have a debate on this. Suppose, what do an average lab charges for a PSA? Anywhere between 800 to 1200. Hospital labs के बारे में मैं कोकिला बेन वगैरह नहीं बोल रही, which will be like 3000. But it is like yesterday's debate. Okay, I'll just shift the topic. I think my 2 topics are playing on my brain because ऊपर infertility चल रहा है. Suppose you have a pregnant female. Okay, forget this PSA, who is high risk in her first trimester. Would you do a second trimester or a NIPT? First trimester is with dual marker with NT and CRL. The specificity goes as high as 85 to some better methods maybe up to 88%. What would you do? You will go, if the patient is affording, post counseling NIPT because 99%. If the patient is willing to take risk, I will straight away say go for karyotyping actually. Similarly, the story here is, I feel that when you have this has been recognized as a screening, okay, nobody says CA125 screening. There are debates happening in Foxy. CA125 cannot be used as a screening method because it can increase in menstruation, endometriosis, forget the further cases, even high AMH cases, PCOS cases. So उसमें तो shock हो जाएगा. But this is recognized as a screening. Say the costing of PSA is 1200 and I don't know about this. If it comes to 1800 or 2000 rupees, doing a test with a better specificity, which can tell you that boss relax, nothing is going to go wrong. If the cutoff is 26.9 and below, you need not even repeat. So the guidelines are better if you do this because both are blood tests. It is like, now ADA has given glyco-HB as a diagnostic and the screening. But again, it's a call which you will take whether you do home blood glucose monitoring for your day-to-day glucose, which is a must, which ADA doesn't say you give it away. But diagnostic parameter में उन्होंने glyco-HB को लाया है. So why not look at one test which is going to give us more ruling out of false positives. That's the thought which is coming ahead. Because if you are doing only PSA, you are just doing a chunk of it. You are forgetting the other parts of specificity. Is what the point is. Correct me if I am wrong. So we choose that test, and if the point is going above 30, then you know what you are supposed to do. If it is going below that, you just monitor the case. And look at the I think that velocity funda is something which we should never forget. I feel all tumor markers, we have to insist, don't go shopping, come to the same lab. Why only tumor markers or immunological markers also? People say, idhar thyroid TSH 4 aa gaya, main iske lab mein jata hu 3.8 aaya. That cutoff is what they jump on, which you should not. I think all of us should try to educate our clinicians. Let it be Dr. Mehta's lab, not my lab, but go there only. Because once you are doing there, that CV sticks there. That variation is fixed to the patient.